and should not be taken as legal advice. Diane will also be presenting our cases later on in the echo. Diane, I'll turn it over to you.
All right, thank you very much. It's truly a privilege to be here today and present. So I appreciate the opportunity. I'm going to go ahead and get my screen there. Hopefully you can all see that. So today the learning objectives are going to be, what are the licensure requirements in order to practice via telehealth? Historically, during the pandemic, there were waivers and relaxed licensing requirements, which helped streamline the ability to do it without as much worry about the licensing aspect and needing to actually obtain licenses. But now with the states declaring end to the pandemic, there's greater focus on making sure that you obtain all the necessary licenses before embarking upon a telehealth practice. So today we're going to talk about the licensure pathways. Single state licenses is one. There are a handful of states that have telehealth waivers in a permanent form, so long lasting past the end of the pandemic. Exceptions to licensure in law, in which gives some practices and professionals the ability to practice very limited and temporarily in a state. And then lastly, we'll talk about how to get the compact licensure as far as facilitating telehealth. So there is no single federal license. That would make things way too easy. So you still have to make sure that you have the ability to practice either in law or holding a license or a waiver in law before practicing within any state's borders. So that creates obviously a patchwork of licensing requirements throughout the United States and even in the territories. And when I say in the slide here, healthcare providers, I'm referring to healthcare providers in the traditional sense, as well as mental health providers. Those individuals also have licensing requirements that necessitate appreciating each individual state's laws. Just as a compliance tip, when you're practicing across state lines, you may want to look at the state that has the most stringent requirements, whether it be documentation requirements, licensure requirements, CLE requirements, or CME requirements rather. What you want to do is try to find the most stringent requirement and then adhere to that, and that will ensure that you're in compliance across all of the states then. That can be quite the ordeal, so I'm certainly not minimizing that, but that would be something to sit down and try to identify. And then as a practice tip, you may want to look at each state's licensing board, whether it be the medical board or the behavioral sciences board, because those agencies will oftentimes have their statutes, regulations, policy guidelines, newsletters, etc. available to you right there on their website with ease of access without having to dig into statute books and without having to have a law degree to be able to find it and interpret it. So just keep that in mind when you do embark upon questions about licensing, that you may be able to self-help by just looking at the licensing board's website. Now, when you're practicing in telehealth, what you want to do is consider where the patient is located. And that's oftentimes in the legalese referred to as the originating site. That typically is what will dictate where you need to be licensed. Generally, it's not where the provider is located. I wouldn't say that, 100% across the board. It's always good to check in that state where the provider intends to be seated to verify that they don't have some unique laws. But generally speaking, it is usually where the patient is located. And that is, differentiated from a patient's normal residence. It is where they are physically present at the time of the visit. How do you know where they're actually at the time of the visit? It would be very prudent to ask and verify, and then document that you've asked and verified and what you were told. There are some telehealth platforms that will actually have technology mechanisms built into them that will verify the geolocation of where the patient is located to ensure that they are within the four corners of the borders of the state where they say they are. So that's obviously a very good mechanism to be able to ensure. But if you're a provider that doesn't have the luxury of having such software platform, then you'd be wise to definitely ask the question, because patients may have scheduled a visit, think it's really easy to do. They can do it telehealth, even though they're going to be traveling through another state, and not appreciate the provider's licensing constraints and restrictions. And so if a provider is faced with a patient outside of the state of where they would anticipate the time and they're not licensed there, then that visit should really be postponed. And the caveats to this general licensure rule that I have here is, of course, checking with each state to make sure they don't have any specific requirements for a provider that is seated in the state at the time. And then a limited ability for mental health providers to practice pursuant to some states' laws, which I'll talk about that a little bit more in depth here as we get further on in the slides. So the pathways to licensure, of course, single state license, that's the old traditional way. We're all accustomed to that, where you apply, whether you're operating in 1, 15, 30 states, but it's applying to each state licensing entity separately, independently, and then getting the single state license back. And of course, that can result in spreadsheets where providers have literally spreadsheets of multiple states with the renewal deadlines, CLE deadlines, other, key triggers, and then having to make sure that those are all adhered to across the board and to stay in compliance. There are some benefits to the single state licensure. I'll talk about those a little bit later in comparing and contrasting with the compact way of obtaining licensure, but that's the one that you're probably most familiar with. And then telehealth waiver, that's newer with regard to Kansas having issued a permanent telehealth waiver. And some other states may have a new category of licensure where you could apply for a full license or a telehealth specific limited license. And Kansas has the total telehealth waiver. So looking at each state to figure out, what types of licenses are even available to get your end goal accomplished is important. In Kansas, this is with the Kansas Board of Healing Arts. So we're talking about the providers that I've listed there that are under the licensing authority of that particular agency. So this does not encompass mental health providers in Kansas, because they don't fall under the Kansas Board of Healing Arts, but rather a separate licensing body. So with respect to those providers only, if they hold an unencumbered license in another state, then they have this avenue available for streamlined licensure, streamlined application process, streamlined approval process, and then obviously that opens the doors to the telehealth. So Kansas really is setting themselves apart here with being very facilitative of telehealth practice in Kansas. There's only a few other states that have similar arrangements. So if you're able to take advantage of that. And when you're looking to see what other states have waivers or even a telemedicine or telehealth license specific, you can look to the FSMB, the Federation of State Medical Boards website. If you haven't happened upon that yet, that is a huge resource. They have a document in which they try to summarize all of the licensure waivers or requirements specific to telehealth. So check that out, and that will streamline your research as well. So another way to be able to, this is probably a misnomer how I have it here, because it's not really a pathway to licensure, but an exception to licensure. As I mentioned earlier, mental health providers, not all, but some states will allow them to practice across state lines in a temporary and limited fashion without the necessity of applying for a license. So if it's going to be, just 1, 2, 3, each state that has this limitation has defined how they're going to, perceive the temporary and limited practice. But if you have a patient and they tell you they're going to be in another state and you want to maintain a scheduled telehealth appointment with them, you might be able to accommodate that despite them not being in their current state where you're licensed, if the other state where they're going to has this. And this is my plug for the Telemental Health Laws app. If I don't know if anyone's seen previous presentations I've given, but I've plugged this every single time. I think it's a wonderful app. I use it, and I did not create it. I wish I had. I wish I could take credit for it, but a national law firm had the resources to be able to publish this app, and it is literally a 50-state survey of laws for all the mental health providers. So psychiatrists, psychologists, social workers, a whole host of other providers as well. And you can click on the state and the profession, and it'll give you a summary of what the licensure requirements are. So it's a quick, easy way. It's free. And as I understand it, it's on Apple. I have Android, and that's where I've downloaded it. So again, kind of a nice practice tip for you to be able to use. All right, and then we have the compact licensing. So the Interstate Medical Licensing Compact is not a license in its own right, but rather it is a process to expedite licensing. So it's like a hub. Individuals that are eligible can apply to this Interstate Medical Licensing Compact hub, and they will house and process the core of the application that's universal state to state. And then they will expedite the processing in the states that the applicant wants to be licensed in. So Kansas is part of the compact, Oklahoma as well. Missouri is not. So Missouri has attempted to introduce legislation, but it has never passed. I don't know if there's legislation that's on the agenda for this upcoming legislative session, but they seem to be a little late to the party. Just for the visual, there's 37 states in total right now that are part of the compact. And so you can see that it does cover a lot of the nation, but there are some outlier states that still have yet to join. So again, another aspect of the patchwork layer. It would be really easy and nice if all 50 states had it, and then you'd have the ability to move freely, but we're not quite there yet. Maybe one day. And of course, the Interstate Medical Licensing Compact has its own restrictions on who's even eligible to be able to leverage this expedited application process. Yeah, it has to be someone that's graduated from an accredited medical school, did an accredited post-grad training, and then completed the USMLE or similar examination, and they've limited the number of attempts per component. And of course, board certification. Sometimes it's that board certification that can hold individuals up from being able to avail themselves of this expedited process. Now, if an applicant does not meet one or more of these requirements, then they are going down that single state licensure aspect, which can cost more money, time, etc. But they still have the single state licensure right to be able to obtain licensure. And the other requirements with the Interstate Medical License Compact is that, of course, they have to have what I call a clean record, meaning be licensed in another compact state, and then not having disciplinary actions, no criminal convictions, not under investigation even, and then they would be eligible to apply as a compact license, as long as they're practicing at least 25% in their principal state. Now, I will touch upon this. So as I said earlier, there are some advantages still to the old single state licensure. And what I meant by that is when you have a compact license and have obtained it through that, it's a single state licenses, not to mix words, but single state licenses obtained through the compact process. Disciplinary action in one state, it has a tendency to snowball and impact those other states where the applicant has licenses in other compact states faster than even a single state license. So that's where there can be some strategic advantages and disadvantages to choosing what route someone is going to go to obtain licensure to be able to practice telehealth in the states that they desire to do so. And then, of course, we have the other professions, so like the nurse licensing compact, which Kansas, Missouri, Oklahoma are all part of that. Again, they do have some of the same types of restrictions as we went over with the medical, in which in order to be eligible for it, you have to have that clean record. You can't have any felony arrest charges, convictions, otherwise you're automatically ineligible for compact license. But otherwise, those individuals are able to take advantage of that, and traveling nurses, that's huge. So hopefully one day we get to 50 states there that are members. And then physical therapy does have the compact states too. And we've got the PSI-PACT, which is lagging a little bit behind, but nonetheless, I think carrying some steam and getting more states each and every year. And that allows the psychologists. In Kansas, it's not open to master level psychologists. So just keep that in mind as well. And then the EMS does have their practice compact. And so that there are actually other professions I haven't included in here, but there's lots of other professions that are undergoing continual conversation about trying to get compact legislation passed to the states. So I think that's just going to be kind of the way going forward, and there's going to be more opportunity for even more professionals as we move forward. So that concludes the didactic portion.
Thank you. As I mentioned earlier, Diane will also present 3 cases to demonstrate how licensure and prescription guidelines inform on services, provide an example of out-of-state temporary practice, and the impacts of requirements on services provided by nurse practitioners and healthcare professionals. After each case, Diane will review the case, and then I will ask for any clarifying questions from our participants before we move into the second one. And she also gives us some recommendations and gives us examples of how she uses that. So I'll turn it over to you, Diane.
Okay. So the first case that I have here is a Kansas, although you could plug in Oklahoma, Missouri for our purposes, any one of those states. Let's say there's a family practice physician with established patients who are scheduled to have follow-up visits via telehealth, and assume that the nature and purpose of the follow-up visits can be accomplished through telehealth without compromising the standard of care. Now, in this scenario, or in this case, the physician plans to snowbird to Florida for the winter and continue to hold those telehealth visits with established patients back in Kansas. I don't know if there's any clarifying questions for that.
Did anyone have a question? I do have a question, Diane. Before you got started kind of digging deep in this, did it matter how long they were snowboarding? Snowbirding.
Snowbirding, yep. Good question. No, it does not matter for this scenario where we're having a physician, a medical physician or a DO physician. It could change if we were talking about a psychologist, right? So, yeah.
Right. And that's why I was asking about that part. So snowbirding. So we'll be in Florida, but then treating patients in Kansas.
Correct.
Okay. Any other questions?
Would you like me to stop sharing my screen at all to help the dialogue, or is there not a preference with regard to that?
If you'd like. Okay. Thank you.
Let me see if I can get that. Okay, So if there aren't any immediate clarifying questions, I'll just go through kind of the methodology that in order to analyze the situation, and then kind of the recommendations. So I think the methodology for the analysis should include what are the laws in the state where the patient is located, Kansas, right? And then what are the laws regarding telehealth in the state where the provider is located? So Florida. Probably unlikely that Florida is going to have any licensing requirements, but you always want to check rather than be mistaken or assume wrong. And then what are the, prescribing authority? If this physician is going to be prescribing to the patient, whether that's controlled substances or otherwise, what's the prescribing authority in the state? Are there any special requirements? Now, since this scenario involves a physician that is typically practicing in Kansas for the rest of the year, but just leaving the state to go down to Florida for a temporary residence, then they're probably really familiar with the state laws, have already had everything established. So it's not as tricky as maybe the converse, where they're, coming into the state, but based primarily in another state. So after checking with the Florida Medical Board, of course, going to the website, seeing if you can find information to self-help, self-educate based on the information available. If not, call and actually see if you can get a hold of a live, warm body to be able to help. In my experience, I find that regulators oftentimes want to help people be compliant. So don't hesitate to pick up the phone and call and ask the questions. In Kansas, obviously the originating site would be where the patient is located, and in the state laws that I've reviewed and seen, it seems like that is the trend. So of course you would want to see what are the Kansas state laws about telehealth, because maybe this provider hasn't done telehealth yet. Maybe it's a family practice that has operated in the traditional sense, and the telehealth element is being implemented now to accommodate the snowbirding down to Florida. So that would be an element, a new element introduced to the practice, where the provider would definitely want to review the statutes on telehealth, the regulations on telehealth. And in Kansas, of course, the standard of care is the same. And so if, for instance, this case scenario didn't go into this, but I'll just dovetail off of it. If, for instance, the visit was for the purpose of refilling blood pressure medication and blood pressure was an absolute necessity, well, unless there's accommodations to have that happen in conjunction or otherwise from the telehealth, obviously the provider can't do blood pressure via telehealth alone. So the standard of care is going to be the same. If in this scenario, if the blood pressure is required, the physician had better figure out a way to be able to get that data before refilling. Prescribing standards in Kansas, even for controlled substances, is the same whether the provider is seated physically in Kansas with their patient face-to-face, or whether that provider is snowbirding down in Florida and seeing the patient back in Kansas via telehealth. But not all states are that way. That's just true in Kansas. And documentation requirements are the same as well. And you're probably aware that Kansas has specific documentation requirements in regulation. And so again, that's we're being familiar with the state laws and the requirements that you can maintain that compliance is important. So that's the recommendations for that case.
Would there be any comments from the HUB team or questions? Any from our participants? I would ask, would you also encourage them to understand in-person established patient versus new patient? Would that be what they would need to do also?
Good question. So some states limit telehealth only to established patients. So again, being aware of what that state requirements are. Kansas specifically does not require it to be established patients only. So in theory, you could still have new patients as long as you're adhering to the standard of care, the appropriate documentation, and then of course, prescribing the same as you would. But Yeah, I mean, that's the legal landscape in Kansas.
So basically, Diane, you're saying, yes, it would be fine because in this scenario, these are established patients and the care is delivered where the patient is, that's the originating site. And so as long as the standard of care can be met, the answer is yes. Am I summarizing that?
You are summarizing it perfectly. Yep.
Okay, thank you. Are we ready for the next case? All right.
Okay, so let me get my share screen back here so you can read along. Okay, case number 2. So the Missouri Bureau of Narcotics and Dangerous Drugs, BNDD, requires essentially what would be the equivalent of a DEA registration in order to prescribe controlled substances within the 4 corners of Missouri's borders. In order to obtain a registration, though, the provider has to have a practice location within Missouri. So in this case, a psychiatrist may be duly licensed to practice medicine in Kansas and Missouri and has a physical location only on the Kansas side of the state line. And if an established patient is seen via telehealth for purposes of refilling a controlled substance, then that patient takes that prescription, or it's sent to the patient's pharmacy in Missouri, because the patient was sitting in a Missouri home at the time of the telehealth visit. So in this scenario, this patient may have gone in person across the state line, selected their psychiatrist on the Kansas side, historically has gone in person, then the pandemic hits, and now there's the telehealth option. And so then they sit in Missouri in their cush home and they have the telehealth visit and they get a refill, and that refill is sent to the closest pharmacy in Missouri. The Missouri pharmacy refuses to fill the prescription because it is not issued by a clinic that has that Missouri DEA equivalent registration. It doesn't have it because it doesn't have a Missouri practice location. So I don't know if there's any clarifying questions to that scenario.
This was a tricky test. Can you hear me? Thank you. This was a tricky case study. I worked a little bit with Diane on this one. Did anybody have any clarifying questions? There's a lot of regulatory questions and boards to talk to. So anybody?
I just was going to add, I believe this case actually was child psychiatry. So just thinking how it might impact both some controlled substances on the child and adult side.
Mm-hmm. Okay. So yeah, this was a tricky case study because there is a gap in the way that the laws are written. It is not facilitative to allow for the telehealth in conjunction with the prescribing across state lines in this scenario. It is an impossible way, other than the practice obtaining a Missouri location to then in turn get the prescribing authority. There is not a way to be able to accommodate that prescribing via telehealth. So then it puts us backwards in having to have that individual come in for that in-person visit to prescribe, to then be able to take that prescription, and then they can go fill it at the Missouri pharmacy. So, it's not an easy situation. It is a good reminder, though, that when we're talking about licensure across state lines, we're not only talking about the ability to practice medicine, but we're also talking about the ability to prescribe. Kansas does not have a controlled substance registration requirement. Missouri does. And so that's that added level and layer of patchwork of licensing that is required in order to do everything, compliant and for the patient to be able to achieve the desired outcome. I know that there are other states, I believe Oklahoma is one that also has that DEA equivalent registration requirement. So Kansas, in the tri-state area, Kansas is one of the outliers with regard to that. I don't know if there's follow-up questions at all. Or
Hi, this is Rachel from Missouri Telehealth Network. I think this case is fascinating, and I wondered if in this case, the way that I read it and understand it, this provider would have to partner with a practice in Missouri, so they would have a physical location, right, in order to treat those patients?
exactly. That would be one way to accomplish it. If they partnered and then had a physical location that they could use to get the additional registration, then they're able to offer the telehealth. This is my editorial 2 cents, but it's a lot of obstacles and burdens in order to get the telehealth to the patient, right? In this scenario. But yes, they could certainly do that.
I know I won't take us too far down the rabbit hole, but I believe an additional question that came with this was also, we've got medical schools that practice across state lines, and we've got residents that fall into similar things, and then getting all of the residents at some level able to provide the service in their residency without having to be licensed at 25 different FQHCs or rural health clinics in Missouri or the state of Kansas was tricky as well. So those types of things come up related to not just established practice, but also those in educational institutions.
Yeah, and hopefully there's conversations that are developing between the stakeholders and the regulators and the lawmakers to hopefully aim towards bridging this type of gap. But obviously that's beyond my knowledge, but that's what it would take in order to facilitate better the telehealth in this scenario.
Can I ask one more question? This is Rachel again from Missouri Telehealth. I recently had talked to someone who was setting up in a particular state a telemedicine family practice. So they would not have a physical location for patients to come, but they would, Diane, have an address. So then because they have an address, I don't know if it's P.O. box or their home or what, but they would be able to go through that BNDD process then, right? Even though it's not considered a clinic. I mean, is a telehealth clinic considered a clinic if there are no patients there? I don't know.
Yeah, you get into the corporate practice of medicine in that scenario too. Because if you're going to establish a corporation, are you a existing in another state, and then you're registering to do foreign business in Missouri, let's say you're established in Kansas, and now you're going to register to do business in Missouri as a foreign corporation. And then you do have to have, for the DEA, and this is the federal, they do not allow post office boxes. I have not looked to see if Missouri has the same stringent requirements or not, but the federal DEA absolutely wants the physical street address. I would suspect, but I don't know for sure, that Missouri is probably pretty similar. Otherwise, it would end run the purpose of why they have the physical location requirement. So yeah, it's a concern for sure. It's certainly an obstacle and a barrier.
Dr. Cunningham, did you want to ask your question? I saw it in the chat, but I'll give you a moment if you wanted to.
Yes, I'm looking at it from a patient view. You're focused on the provider, and that's a good discussion. But what if your Kansas patient is a snowbird and wants to refill while they're in Florida, can they, if they have used a chain like, we'll say Walgreens or Walmart that has outlets, are they allowed to be refilled?
Yeah, I mean, that's an excellent question to talk about the converse. So if you're looking at it from how are they going to get the refill? Is the standard of care that the physician has a visit with the patient before they refill it? Then that physician would be required to have a telehealth visit. And then they would, if it's standard of care that they can have that visit and refill it, then that physician is going to have a problem if the Florida laws require a registration, same thing as Missouri, right?
Right.
So, and then the physician is going to have to also, do they have a compact license that allows them to do the telehealth visit in Florida where the patient is, and that's the originating site of the visit. So you've got not only the registration issue, but also the licensing issue in that scenario.
So it's a mess.
Can I add something? Can I add
As
something?
a historical view, as a retired anesthesiologist, I practiced in hospitals, my anesthesia, trade, but my BNDD number, when I had one, was at my home, because that was where my billing office was.
Mm-hmm.
So Missouri did allow me to do that because I was an independent contractor and not an employee of the hospital. So it wasn't appropriate to use a hospital address.
Sure.
Can I add something? Diane, historically, in the Medicare population, in the Medicare law, back when I was practicing, I was aware that historically there was a caveat in deep down in the language somewhere where they allowed, I can't remember if it was 12 or 20, one of those two. They allowed so many visits, and this is before the pandemic, this is before the explosion of telehealth. They allowed so many visits for your patients that travel to other places, even if you didn't have a license in that state. The Medicare law allowed you to do that exact thing for a limited number of people per year. So,
well, and that raises a good topic that'll just piggyback onto as well. You have the layer of the Medicare reimbursement rules as well. So not only licensure, not only DEA or the equivalent registration, but also the reimbursement rules and making sure that the companies that you're credentialed with, you're staying within the policies, procedures, and requirements of those insurance companies. With regard to if there was an exception for the Medicare reimbursement about seeing folks so many times, that would be separate and apart from even the state licensure requirements. So Florida would certainly, unless they piggybacked and wrote into their law a similar parallel exception to licensure, which they could, or any other state could, but absent they writing into the state laws for the licensure aspect a similar exception, then you still have that trifecta of concerns to be considering.
There was a question about can a rented street address like what UPS offers work for registration?
Yeah, I don't know that off the top of my head as I sit here right now. I do not know the answer to that. I'd be happy to look into that.
We're getting a couple of the address questions. Another one was that we may add is a general delivery address if clients and patients are without homes or without work.
Yeah, so it's not the address of the patients as much as it is if we're referring to the practice physical location requirement for the provider to get the BNDD registration, that would be focused on the provider's address. And then it's what's sufficient to constitute that physical location. Does the provider have to have a physical street address of an affiliate, practice or hospital, or can the provider have a PO box or a home residence. So the question as far as what will satisfy that physical location, I don't have the direct answer right now for that.
Would that be a question for, would that be the BNDD or
Yes, exactly.
depending on state?
Correct.
We do have another question, and I'll go ahead and read it. And then, John, if you want to come off mute to add any clarifying, please do. Is there an originating site for asynchronous e-consultation, like physician to physician? What state licensure considerations are there in this case?
Yeah, and that's a great question. That is going to be dependent again on state by state laws. Kansas doesn't require that, licensure based on physician to physician consultation. It is going to come down to, how is the defined practice of medicine and what are the definitions specifically in any telehealth laws in each state? Are they defining the practice of medicine to include that physician to physician consultation to necessitate licensure, or are they defining it to be a physician to a patient interaction and treatment and diagnosis? And so that is another aspect or angle to be looking at the situation as far as what are the requirements in each state.
And historically, can I just say that physician to physician consultation happens all the time, all over the country, and it's not direct patient care. And so it's not regulated in that way.
But in this case, it's a little bit different than what we've traditionally done because it's a written consultation typically, and it is billed for. And so it might be viewed differently than just the discussions that we've had forever.
Okay, thank you. Looks like we're at 15 minutes left, so we can move to the next case.
Okay, let me go ahead and share my screen. Okay, case number 3. So this is involving the Kansas legislation that changed effective July 2022 to eliminate the requirement for advanced practice nurses to have collaborative physician agreements. So if there's a Kansas licensed APRN who also holds an RN license, and the RN license is a compact license. So I think I sped through the picture before about the compact license for nursing, but that compact license is for RNs, not APRNs. APRNs are one of the professions that are trying to get steam to get a compact license in place, but there's only a couple of states that have joined on so far. So that nursing compact is RN only, not APRN. So we have a Kansas APRN who holds an RN though as well, and that's a compact license. So this APRN establishes a family practice clinic in Lawrence, Kansas, let's say, and offers telehealth visits to her patients. The Kansas APRN has an existing patient that is requesting a telehealth visit while that patient is sitting across the state lines in Missouri. So that's the case presentation. Are there any clarifying questions on that before I dive into the analysis? Yes.
This is Rachel. I've got a question. Just based on the facts that you presented, I'm wondering, if I understood it correctly, the advanced practice nurse in Kansas doesn't have a collaborating physician requirement, so they don't have one.
Correct.
In Missouri, there is a requirement for a collaborating physician, and that advanced practice nurse does not have that relationship in Missouri.
Correct.
Okay.
Yep. Great clarification. Okay, so that leads me into the conversation about, oh, how do we tackle this analysis? What's the methodology? So in this scenario, the patient is in Missouri, presumably would be in Missouri if that telehealth visit was held. So Missouri is the originating site, and the nurse compact is only for the RNs. So we know that the APRN doesn't have automatic licensure to practice as an APRN in Missouri, but rather separate single state license would be required before this APRN could conduct that telehealth visit with that patient being seated in Missouri. And then, of course, Missouri would require the collaborative physician arrangement, which is different from now, what Kansas's new laws are. So then that APRN would also have to have that collaborative physician relationship established in order to be compliant with the Missouri requirements. And depending on the nature of what the telehealth visit is, if that APRN was going to be prescribing controlled substances, we also know from the prior case discussion that the DEA equivalent registration would be required. But even if that nurse wasn't doing the controlled substances, you still need to have the license, in the single state license in that other state, because there is no compact license for APRNs. And then the physical, well, the license and the collaborative arrangement. So just wanted to draw that distinction between the limits of what the APRN can do across state lines and the comparison and the distinction between how the relationship would have to be structured between Kansas versus Missouri, given the new change in laws. And again, the APRN would still have to make sure that that visit standard of care was adhered to, etc. Any questions about that one?
I do have another question.
Yes.
I was in, so just to preface by saying, I had listened to a talk about standard of care a few years ago, and it's my understanding, and you can tell me if I'm wrong, is that standard of care is like local or regional.
Yeah,
So
no,
if you're like trying to accommodate for a standard of care in a place that you don't live in, how do you know what that standard of care is?
Yeah, standard of care, there is an element that becomes local, right? It's not always an element that comes into play. But if, for instance, this is the easiest hypothetical that I can give as far as disparity of standard of care. There might be an urban hospital and a surgeon has all the resources and all the staff, and they're well-trained, just the top elite type of physician in their field. So the standard of care may be a little bit higher in that scenario versus the standard of care in Western Kansas, small town, where not the same resources are available to the surgeon in the operating room. Maybe there's different devices, access to resources, etc. So that physician in Western Kansas is going to get the benefit of understanding the context that they are operating in. And I mean, like business operating versus the other. But if we're talking about a family practice APRN from Lawrence to the greater Kansas City metro area on the other side, there's not going to be a whole lot of difference in the standard of care. The standard of care is going to be universal in that scenario. So it's a very much, it depends as far as how much does the locality play into that analysis. Any other questions?
Okay, well, we have a few minutes left, so I think the general takeaway from those three cases would be understanding statutes and regulations within your state practice and then the state you're going to go to. Also having a patient perspective in terms of where the patient's going to be located, maybe the end user patient experience and what they would need to know, be able to do to complete have their continuum of care. Also contacting the regulatory bodies in terms of prescribing, DEA and BNDD, things like that. And then also I did drop quite a few links. Sorry if I overloaded everybody. I do like to do that in real time in case you want to save them before we send the slides out. So I sent a couple out, including the 2 apps for Apple and Android for the telehealth laws licensure, and then also some of the compact websites related to nursing, physician, and then also the SciPac. So if you haven't had a chance to dive into those related to your own practice, I did put those in the chat. And then I also did put in our email address. If you do have any additional questions, please let us know because we can follow up after the echo. Otherwise, I think we're just about finished with this one. If anybody else has any other questions or comments. It's a lot to unpack with